Hello dear students, welcome back to my YouTube channel Physiology Learning. Today we are going to continue with our blood pressure regulation, and we were discussing about the short term regulation of blood pressure. In this video we will be continuing with the short term regulation of the blood pressure. So in blood pressure regulation, just a small recap, we have classified them into short term, then intermediate and long term. In the short term, in the previous video we saw one important regulator, that is nothing but our baroreceptor. In today's video, it is going to be a very short and simple video. We are going to see about the chemoreceptors and CNS ischemic response. So baroreceptors, I have told you, like it is operating range is 80 to 180 mm of Hg. So naturally, most of our BP range is between this 80 and 180. So we will not be needing the chemoreceptors or the CNS ischemic response in a regular day-to-day life. But when the pressure starts to fall below these levels, then there are additional backup mechanisms which will act and control the short-term regulation of blood pressure. So what is the chemoreceptor operating range? Whenever the BP falls, the mean arterial pressure falls below 70 mm of Hg, then the chemoreceptor will start to act. So what are its stimulus? Chemoreceptors, as the name indicates, they are going to sense the chemicals. So what are the chemicals that is going to sense us? Whenever there is a severe decline in O2, that is a decrease in PO2, or an increase in PCO2, the increase in carbon dioxide levels, or an increase in H+. So all these three are the stimulus for chemoreceptors. In the respiratory system also we saw the chemoreceptors are going to function. It is the same chemoreceptors which is going to act in the respiratory system also. They are present in the two regions. One is in the arch of aorta, which is called aortic body, and another in the bifurcation of the carotid in the carotid body. In the baroreceptor, we saw that there was sinus, the carotid sinus, and the aortic regions. Here it is aortic body and the carotid body. And the afferent, they are going to travel through the same nerve, whereas the carotid body is going to travel with the cranial nerve, that is glossopharyngeal cranial nerve number 9. So these are the two cranial nerves which are going to carry the impulses to the center. So once the chemoreceptor receives the impulses, they are going to carry it to the central nervous system and they are going to reach the medulla. Like the baroreceptors, here also they will reach the medulla. And after reaching the medulla, whenever there is a decline in BP, so they are going to respond for a decline in BP. So what will be the ultimate effect? The ultimate effect is pretty simple. There will be an increase in BP. How does it do is, it is going to directly stimulate the center, which is called as RVLM. In the baroreceptor visa, RVLM is nothing but a sympathetic system. So RVLM, we already knew it is nothing but a sympathetic system. So when the sympathetic system is getting activated, it is going to cause increase in the stroke volume as well as vasoconstriction in the vessels and increase in blood pressure. But the effect on the cardiac heart rate, it is going to vary depending upon the type of hypoxia. Whenever a patient is having a mild hypoxia, suppose the patient is having mild hypoxia, at that time what is going to happen is it is going to stimulate the cardio-inhibitory center. So it is going to stimulate the CIC. Cardio-inhibitory center, if it is stimulated, what is going to happen? There is going to be an increase in the vagal efferents. This vagus is going to decrease the heart rate. So there is a catch here. Generally, the BP and the heart rate increases simultaneously. But in case of mild hypoxia, what is going to happen? The BP is going to increase, but the heart rate will be decreasing. You might ask me, the heart rate decrease is not a good option. Why? Because the heart rate has to increase to enhance the cardiac output. But this is happening in mild hypoxia. But when the patient is having a severe to moderate hypoxia, whenever the hypoxia is increasing to moderate and severe levels, what is going to happen is now the respiratory center is also working, because I told you the cardiac, carotid and the aortic, they also respond to the respiratory stimulus. There is going to be an increase in respiration and there is going to be increase in stretch of the lung. So whenever this stretch of the lung increases, it is going to carry the vagal efferents from the lung and they are going to inhibit the cardio-inhibitory center. So naturally, if the cardio-inhibitory center is going to inhibit it, there is an increase in heart rate which is going to cause tachycardia, which is more favorable. So as you can understand from this, in case of mild hypoxia, there is a little, I would say, not expected reaction is happening. There is a decrease in heart rate. But when you talk about the action, this decrease in heart rate is also called as direct action. Why it is called direct action? Here the chemoreceptors are directly stimulated by the changes in BP and they are going to enhance the CIC. But whenever they are acting on the respiratory system and indirectly they are causing a tachycardia, this response is referred as indirect response. So this is one area where you have to remember it carefully. So these are the chemoreceptors. So the chemoreceptors, as we saw here, their operating range is less than 70. So whenever the BP falls below 70, it is going to act and try to bring back the BP to the normal levels. If the BP is falling and falling and falling, and the levels, whenever it goes below 50, and especially when the levels go below 20 or 30, whenever it goes below 20 mm of Hg, below 50 also it can start the CNS ischemic response, but most preferably when it goes below 20, it is going to start. As you can see from this value itself, below 20, it means that the person is almost in a very, very severe, drastically worse condition. Only in those worse conditions, it is going to get activated. So what is going to happen here is there is going to be hypoxia to the medulla. The entire medullary region itself is not getting a blood supply. So what is going to happen is here there is going to be an activation of direct activation of RVLM. Please note down this. Here it is RVLM which is directly activating it. So there is going to be a severe sympathetic stimulation, and this can increase the BP. If you cannot guess the levels of BP rise also. It can increase from 20, it can go up to the levels of 220 mm of Hg also. It is such a powerful system, but only the disadvantage here is this increase in BP is going to last for a very few minutes. It is going to last for a few minutes. So just 2 to 3 minutes we can say. So this mechanism is also has been given a special name which is called as last ditch stand. What is this last ditch stand is? The body makes one final effort in order to save the person from a fall in BP, hypotension, by increasing this BP to very, very high levels. As you can see here, the only disadvantage is it is going to last for a few minutes, and it is obviously an external intervention is needed. And there is one more reflex called as Cushing's reflex. It is not a Cushing disease, it is a Cushing reflex. What is this Cushing reflex is? This is also a form of CNS ischemic response. CNS ischemic response can happen due to hypoxia due to multiple reasons. Suppose there is a infarction to the RVLM, then also it can happen. Or some vessels are being compressed, then also it can happen. But if it is specifically happening due to an increase in intracranial tension, whenever there is an increased intracranial tension, this rise in intracranial tension, as you can know, that cranial vault is fixed. So there is a CSF, there is a blood vessel, and there is a brain tissue. Now what is happening? The CSF is raising the intracranial tension, and it is compressing the blood vessel. So there will be a compression of blood vessel. If the CNS ischemia is happening because of raised ICT, then it is called Cushing reflex. Compression of blood vessel is going to happen. Because of this compression, what is going to happen? There is going to be stimulation of RVLM, and this RVLM is going to increase the blood pressure. And there is a triad of changes which is happening with respect to this raised intracranial tension. One of the triad is nothing but the increase in blood pressure, that is agreed. Whenever there is an increase in blood pressure, who is going to get activated? The baroreceptors are going to get activated. And baroreceptors, whenever they are getting activated, what is going to happen? They will try to decrease the BP, decrease the heart rate. But can it decrease the BP here? There is a rise in BP, but can it decrease the BP here? It cannot decrease the BP here. Why? Because this BP rise is directly influenced by the RVLM. But because of this BP rise, what is going to happen? This BP rise is going to go and inhibit the cardio-inhibitory center. This rise in BP is going to stimulate the cardio-inhibitory center. So whenever there is a stimulation of the cardio-inhibitory center, what is going to happen? There will be a bradycardia. Because of the rise in BP, the bradycardia is happening. Because of the rise in BP, here there will not be decrease in BP. The answer is because the RVLM is directly stimulated in this condition. So now the RVLM is not going to listen to the CVLM. The CVLM cannot inhibit the RVLM. If you go back to the baroreceptor video, you can understand that generally the CVLM can inhibit the RVLM, but here the CVLM cannot inhibit the RVLM because it is directly stimulated and it will not get inhibited. And not only that, the respiratory centers are also located in the medulla, so there will be an irregular respiration. Irregular respiration. So this is a triad of Cushing reflex: increase in BP, reflex bradycardia, and irregular respiration. So this is all about the short-term regulation, wherein we saw about baroreceptors, then chemoreceptors, and CNS ischemic response. Then there are two different forms of waves which can happen because of the fluctuations in the BP. One of them is the Traube-Hering wave. What is this Traube-Hering wave is? The changes in BP with respect to respiration is called Traube-Hering wave. The concept is pretty simple. Whenever we are taking a normal inspiration expiration, there is a fluctuation in the BP. Why it is happening like that? During inspiration, what is going to happen? During inspiration, there is a fall in BP. Why? Because whenever we are inspiring, what is going to happen? Our thoracic cavity is going to expand and the venous return to the right side of the heart is going to increase. Increase in venous return to right side of heart. And because the right side of the heart is having more blood now, there is a fall in BP. Because BP is directly proportional to the ventricular output or the left ventricular output. So during inspiration, because of the negative pressure increase in thoracic cavity, there is an increase in venous return, there is a fall in BP. During expiration, there is a slight increase in BP, especially during the early part of expiration. So this is normally happening in all of us. There is a change fluctuation in BP during inspiration and expiration. How much changes is going to happen? The changes is going to be very minute. The changes will be very minute, around 2 to 5 mm of Hg. There will be very minute changes in BP during inspiration and expiration. Suppose the fall will happen during inspiration and the rise is happening during expiration. So this type of fluctuation is called Traube-Hering wave. How will you identify Traube-Hering wave? Is the fluctuation is going to be very low, and the number of times the fluctuation is going to happen will be similar to the respiratory cycles. In a normal human being, the respiratory cycle is around 14 to 16 times. So this also will happen around 14 to 16 times. Then coming to the next set of waves, which is called as vasomotor wave or Mayer wave. This does not happen normally, but this happens whenever there is an issue or a patient is having some fluctuations in BP because of the reflex mechanisms that we discussed. Suppose let's take an example. A patient is bleeding. His blood pressure is around 120 and now the patient is bleeding. So what is going to happen is blood pressure is going to come down. Let's assume the BP has come to, let's say, around 100 mm of Hg. And after that, now the baroreceptors will get activated and it will try to bring in the BP back to the levels of 120. But let's assume the patient is still bleeding. This happened because there is a bleeding which is going on. This patient is not yet brought to the hospital and still bleeding is happening. So what is going to happen to the BP? Again it is going to fall down. Again it is going to rise up. Again it is going to fall down. Again it is going to rise up. One major difference you can see in this is the BP fluctuation is wider. It is around 50 to 20 mm of Hg or 30 mm of Hg also it can go. So this type of wider fluctuation which happens due to the vasomotor centers in the brain is called as Mayer's wave. Sometimes there will be huge wider changes. For example, let's assume the same patient 120 mm of Hg and the BP is falling and it has fallen below the levels of 80. Whenever it falls below the level of 80, what is going to happen? Here, just assume this is 100, but now the BP has fallen, let's assume less than 80. Who is going to get activated? The chemoreceptors. So the chemoreceptor will try to push the BP. When it reaches the 100 levels, now the baroreceptors can take over. Now the baroreceptors will try to increase the BP. So as you can see here, it can go with a very wide fluctuations. But if intervention is not done, what is going to happen? The patient is going to die. And this is the type of fluctuation, BP fluctuations, you will see in a patient who is having a hypovolemic shock. The patient is bleeding and before we are arresting the bleeding or before the fluid therapy is started, what is going to happen to his BP is, his BP is going to go up and down, up and down and up and down. So that type of response which you see in the patient is called as the Mayer waves. So this is not normally seen, these are abnormal waves. And here, how will you differentiate it from a Traube-Hering wave? One thing is the fluctuations are higher. And generally, this type of variations, like the baroreceptor has to act, it has to send the impulses to the brain. So it is not going to happen very frequently. So it is going to happen around 3 to 6 times per minute. So that's a major difference between the Traube-Hering and the Mayer wave. I hope it's clear. Thank you for watching the video. Stay tuned for more such videos. Thank you so much.